Now, for anyone that's here for the first time, we don't give medical advice. We just share experiences. If you hear anything of interest, go along and talk to your urologist, your oncologist, or your doctor, and get confirmation from them. Just like to welcome everyone to the meeting today, and as we might have Peter talk first, because Peter wasn't able to, I don't believe, finish everything at the last meeting. If he'd like to give us an update, I'd really appreciate that. Thanks, Peter.
Okay, thanks, Nev. Thanks, everyone. Just to recap, in early February, my oncologist decided that he'd have a look at putting me onto lutetium-177 because I was castrate-resistant metastatic prostate cancer, and I wasn't dealing all that well with enzalutamide. The PSMA PET scan disclosed the tumours had reduced to a fair degree from the previous one, so he decided instead to put me onto abiraterone or Zytiga. At the 3 months review, I was at the stage where I was having severe depression from it, something that I had not experienced over the last 4.5 years. So he decided he would like to do another PSMA PET scan and then start me on lutetium-177. In the reviews that I had done on the internet, it seemed to me that lutetium-177 was really good for men with a high degree of metastatic cancer. Mine, I didn't believe was in that area. So I went back to see my radiation oncologist just for his advice, see if he could provide me some further information, because unfortunately a lot of the oncologists these days don't hand out any information on treatment. They expect you, well, particularly up here in Brisbane, they expect you to go and do your own research. So my radiation oncologist looked at the scans and he said no, it was too early for him to be considering lutetium-177, but he thought perhaps some stereotactic radiation to a couple of the areas that I have, showing up that there was still cancer might help me, because my PSA levels were the PSA levels were low, but they were basically doubling every 6 months, every 6 weeks, sorry. So I went from 0.5 to 1.1 to 1.8. So he was a bit worried about that. So instead, he referred me to a peer group review, and there were 3 other oncologists, 2 from the Wesley, 1 from Greenslopes and Royal Brisbane, plus himself. They reviewed my file. They all agreed that it was too early for lutetium-177. 2 of the oncologists didn't believe that stereotactic radiation would help reduce my PSA, whereas the chap from, well, he was an associate professor from Greenslopes and Royal Brisbane, said it might be worth a try. In the end, they all agreed that I needed to go on a different ADT, which was darolutamide. So this will be the 3rd novel drug that I've been on for prostate cancer. So I've started that in conjunction with quarterly injections of deferraline. But I don't know whether any other people have been on darolutamide at all, but I'm finding severe tiredness. I have to have 2 sleeps a day. I'm getting a rash on my legs. The bone and joint pain is next level. But I have to stick with this for 3 months. I don't go back to see my radiation oncologist until September. So I'm just hoping that I can put up with those side effects in the meantime. So I'll sort of put it out there. If anyone has any experience with darolutamide or Nubeqa, whichever one you want to call it. So that's where I am at the moment, Nev. I'm sort of in no man's land. I don't know what'll happen if the darolutamide does not reduce my PSA.
Thanks for that, Peter. I don't. Yes, Alan.
So just a quickie. Can you just remind me what the PSMA PET was showing?
It's my initial PSMA was prostate, lymph node, spine, and 2 ribs. The latest PSMA showed that the tumours had increased in the ribs, stayed much the same in the spine, but there's new ones in the para-aortic area.
Okay, thanks for that. I would tend to think that the guys in that panel that said, or the guy in the panel that was suggesting stereotactic, probably too late. Normally a maximum of 5, some only say maximum of 3, but the pattern that you've just described would probably suggest to me that that possible horse has bolted. The issue with darolutamide, how long have you been on it?
I only started on the 19th of June, so it's early days, but
it is. So maybe it's easy for me to sit here and say, look, just suck it up, but maybe you haven't given it enough time yet to allow your body to stabilise to a new drug. It's one of the benefits of that particular anti-androgen drug is that it tends to limit access of the medication to the brain. The blood-brain barrier is not available to it. So I'm not trying to minimise the importance of those side effects, but if you need to have an extra sleep, have the extra sleep. That'd be my suggestion, and just see how it is after another month, maybe. You probably would find that your body will adapt. It is a pretty effective drug. I think in terms of my other question was, have you at any stage had docetaxel chemotherapy?
I went through the whole process of that, Alan. I had 6 sessions of docetaxel, 39 sessions of radiotherapy. And I've been on, this will be my 5th hormone therapy treatment.
Yep. That's fine. It's I would tend to say reopen the dialogue with lutetium. I would have thought that the doctors that are saying it's too early. I can't. I mean, I know for a fact there's plenty of people who have been through the lutetium program at Peter Mac that you would be very similar to. It's the Princess Alexandra in Brisbane that does it.
No. As far as I'm aware, lutetium-177 is only available at the Wesley Hospital where I go.
Right.
The Princess Alexandra have got a different study on at the moment, and I've tried to have a look at that, and so has my radiation oncologist, but it's very hard to get into. It's a trial only. They don't do lutetium-177, from what I understand.
It would depend on what the trial was. I don't know what that would be, but certainly keep trials open. Mentally, it's certainly a very important part of your strategy. But in terms of whether you should or shouldn't use lutetium, not my call, obviously. I'm not a doctor, but it would seem to me you'd be a candidate. Yeah, that's all really I've got to say now.
Thanks, Alan. I don't know of anyone on the call today, Peter, that's on darolutamide. I'm sorry. I think the trial that you spoke about at the PA, there's a guy from Toowoomba going to be on that trial, and I'm not too sure that it's not lead 212 or some number like that. So, yes, Yanni?
Have you given any thought to apalutamide? That's another one of the newer generation androgen treatments.
No, the four of them together decided darolutamide would be better for me because of the deep depression that I actually was experiencing with the Zytiga.
Yeah, that being said, though, and acknowledging that the darolutamide has advantage in the blood-brain barrier area, every drug has marginally different side effects. So maybe it's worth giving apalutamide a crack just to see how it affects you.
Well,
just saying.
Yeah, thanks, Yanni, but I basically have to be on this for 3 months to gauge whether it's going to be successful in reducing the PSA to start with. So,
any other comments or questions to Peter?
I think just a quickie. What you mentioned, I think, Nev, that lead 212 is a current fairly promising radiopharmaceutical along the same lines as lutetium. I'd say a little early, but keep all those sorts of trials in mind. They might be very relevant for you. Just keep across them and maybe make sure you keep the topic alive with your medical team.
Thanks, Alan.
And actinium.
Yes. Tony here. Just a couple of comments, Peter. I think if the darolutamide does succeed in reducing your PSA and the various lesions that you've got, then it might be worth revisiting the stereotactic radiation at that point as a possible thing. I mean, you may have lesions where stereotactic radiation at the moment where stereotactic radiation is not suitable. But if the darolutamide or apalutamide or whatever can bring it down a bit, then the stereotactic radiation option might come back into play.
Yanni, you wanted to say something?
No, sorry, I was just scratching.
Oh, sorry. I thought you were suggesting actinium. That was all. Yeah, and I don't know that it's available in Brisbane, so I don't. Yeah. Any other questions or comments to Peter? No other comments or questions?
Hang in there, mate.
Yeah, we're all thinking of you, Peter. It's not easy. Now we've got a couple of new guys on. Do either Paul or Nick want to give us a bit about their story? We'll try you first, Nick, if you're okay with that.
Okay, Nev, yeah, I'm fine with that.
Yeah, good. Thank you.
Start talking now?
Yeah, yep.
Okay. I'm not sure if I'm in the advanced category or the metastasized category just yet, but I've had a prostatectomy 7.5 years ago. And after that, my PSA was never low. It was 0.5. And over the subsequent 5 years or so after that, it dropped down to 0.05, and that was all great. But it's in the last 9 months, it's kind of gone up, and it's shooting up. I'm not sure if it's quick or it's high, but it's in the last 6 months, it's gone from 0.05 to 0.34, and I'll be having my second PSMA scan next Monday, and results on Wednesday. So just to see if it's what's happening and what's going on and that sort of thing. So I thought this morning I might. I used to go to a prostate cancer support group at Cessnock, which folded about 4 years ago, unfortunately, and that was really good. I was there for 3 years or so, just learning about everything, and I thought I'd attend this morning just to get some ideas and listen to what people have, just in case my situation becomes something, or it comes back, if it recurs.
Well,
Yeah.
I think the bad news for you, Nick, it has already reoccurred.
Yeah.
And the other bad news is you are in the advanced prostate cancer support group legitimately. But the good news is it doesn't have to be a death sentence.
No.
So, yeah, so I'll put it out there for anyone to make a comment. Yes, Alan?
Your situation is pretty similar to what mine was. Let me emphasise, 21 years ago, right? Prostatectomy hadn't prevented a little bit of micrometastasis, which is where a few cells manage to burrow through the membrane and jump into the lymphatic flow or the blood flow in some cases and take up residence somewhere else. In my case, this is in a number of lymph nodes. So there are a bunch of treatments to hold it at bay, as I've just indicated. For me, it's been 21 years, and right now my PSA after the most recent treatment has got back down to virtually off the scale as yours almost. So yeah, don't be too anxious about it. Keep across it with testing and just get as au fait with the alternative treatments that there are, so that when you come to talk to your doctor, and I'd suggest with recurrent disease or recurrent PSA, probably a time to start contacting a medical oncologist rather than a urologist.
Yeah,
that's where your future almost certainly is going to go, and the earlier I would think the better.
Yeah.
Thanks for that, Alan. Nick, it'll be interesting, really interesting to see what your scan comes up with, and that'll sort of dictate the treatments that you're going to have in the near term, I would imagine. But there's, as we said earlier, there's guys here been on treatment for a long, long time. I started hormone therapy back in April 2011, and my PSA still remains undetectable. So
yeah, right.
Yeah,
oh, cool.
there is life after advanced prostate cancer for many, many men. Now, any questions or comments to? Yes, Tony?
Just reinforcing what Alan's been saying, I've been on this path now for 21 years as well, after an unsuccessful radical. My PSA currently is 0.03. So, you know, and it's been up and down, maximised at about 70 at one stage. So,
yeah, right.
So it's a long journey potentially, but don't lose hope. There's lots of things that can be done to help you along the way.
Oh, thanks, Tony. That's cool.
Yeah, back in I was diagnosed in 2009, Nick. There was limited numbers of treatment back in those days. In the years since, there's been heaps and heaps of different treatments come available. So yeah, things are going the right way. Now, not everything works for everybody, of course, but you'll be unlucky if you can't find something in there that helps you for a fair while, that's for sure.
Yeah.
So you will. So yeah.
Cool.
Yes, Yanni.
So I'm in the same boat as Nev. I got diagnosed in 2011, and I've been after an unsuccessful radical prostatectomy, been on radiation treatment and on first generation hormone treatment and now second generation hormone treatment. What I would suggest though is that if at all possible, depending on how many lesions you have, as I think Alan said earlier, 3 or 5 is the limit for stereotactic radiation. But if you can, start off with stereotactic radiation to zap the motherships and prevent little satellites zooming all over the place. The longer you can delay hormone treatment, the better, because when you start taking hormone treatment, then you are ultimately on the path to castrate-resistant prostate cancer, and that becomes significantly more difficult to deal with, particularly when it gets into the bones.
Mm. Mm.
And keep records. Keep all of your records.
I just add one more to that. If you haven't yet had a bone density test, just to keep yourself having a baseline, if you like, if you do go to hormone treatment, as may well be the case, it's certainly the most common pathway for most guys. Then having periodic bone health checks is important, and having a baseline before you start that treatment's a good idea. It's a DEXA scan. Your GP can order it for you. Typically, you'd have it every 2 years, so keep that one at the back of your mind. And the other one at this stage is the more you can focus on keeping yourself physically fit. Exercise is probably one of the best treatments you can have. Both aerobic and resistance exercise, and finally diet. Aware of a heart healthy diet is generally a prostate healthy diet, so not too much. Try and avoid red meat where you can, and plenty of veg, plenty of fruit. Not too much carbs, particularly the processed carbs. So they're basic health issues, and this is a really good time to wind up your antenna on those sorts of lifestyle choices.
Do you mind asking you how old you are, Nick?
I'm 56 now, just turned 56 last week. I was 45 when I had a random blood test for a cold, and the doctor also put PSA down on it, and at 45 my PSA was 10.3.
Right.
So I had the prostatectomy at 48, and it took 2 biopsies to find the cancer, though. So there was delays, unfortunately. The first biopsy, which I had about early 46 years old, it didn't find it. And I had symptoms after that for 2 years, which the specialist at the time was saying it's prostatitis. So I'm eating these antibiotics. And I just got back to him after about 2 years and said, well, something's going on. And I had a perineal biopsy, which found it at the front of the prostate, apparently. And then I had surgery 3 months later. So it had clear margins, apparently, but the PSA reading was higher than it should be, of course. And then 3 months later, I had a first PET scan, which was clear. But it seems to be that over the years it's been dropping. But the specialist said it was ectopic. I had a piece of ectopic prostate left, and now it's rising. I'm not quite sure if that theory is correct. So we'll find out more next week.
Yeah. We look forward to those results.
Yeah, I'll get back to you next month and let you know.
Well, the PSA is a pretty good guide that something's still got active prostate tissue there, metastatic or otherwise. The prostate bed is certainly a good first step, and I think you'll find that the follow-up PSMA test, particularly done when the PSA itself is a little higher and the scan a bit more sensitive, if there is anything in the prostate bed, they'll pick it up. If it's in a lymph node or elsewhere, they should also pick that up if once your PSA is up to a level of 1 or thereabouts. You are pretty young to be encountering prostate cancer, and it tends to be that you have to be a bit more on the front foot in dealing with it when you've got a younger onset disease. So just keep that in mind when you're talking to the docs. Don't go into any, delaying sort of strategies.
Jim here.
Yes, Jim.
I'd like to address that point, Nick. Hormone therapy will bring your PSA down rapidly, and that would interfere with any chance of stereotactic radiation. So I'm agreeing with Yanni that stereotactic radiation should be done quickly. But then no delay after that on starting the hormone therapy. I started mine 14 years ago, and it's been undetectable since then. So, yes, try for the stereotactic first, but then as rapidly as possible on ordinary hormone therapy for starters. So, yep.
I'd agree with that entirely.
So that would be the pathway, radiation, then hormone.
Well, we're not giving you medical advice.
No, I know you're not. I know you're not. I remember someone saying at the Cessnock place I went to, the support group, a speaker came along and said the usual pathway is surgery, radiation, medication. So,
well, radiation sort of, if you're talking about cleanup generally with external beam radiation that covers a big part of the pelvis and so on, that's one thing. The stereotactic that Yanni and Jim have mentioned is spot welding, and as long as they're identifiable on the PSMA PET, and they're not in a completely inaccessible spot that might cause you other damage, and this is really high precision treatment. So I think it's fairly likely it would work unless you've got a whole bunch where it's got too many to treat. But I agree with what Jim said and what Yanni said. It's certainly a good place to start.
Yeah.
But don't delay if if it doesn't work.
Okay. Yep.
Just to clarify with Nick said radiation first, but what we were saying is the type that will burn spots, stereotactic radiation, not necessarily the other kind of radiation which might be widespread, as Alan said, or just to the bed of the prostate, that is where the prostate used to be. So we were talking about stereotactic, or I was anyway, talking about stereotactic radiation would be first off. And I don't know that the radiation to the bed would be worth holding off the. So I don't think that holding off the hormone therapy for ordinary radiation to wherever you have it would be a best idea. But your doctors will be able to help you with that.
Yeah.
Anyway, it'll all come down to exactly what the scans show next week. So it will. That'll be the most important thing.
Yeah, that's right.
Anyway, we certainly wish you all the best, Nick, and hopefully the scans are very conclusive next week, and they get something that they can work on fairly easily and rapidly.
Yep.
Any other questions or comments to Nick? Righto, Mark, it's been a while. Yeah, you'll have to unmute yourself. You have to unmute yourself. Yep, you're unmuted. You're all good now. Last time you were with us, you were worried about feeling tired, and you were going to look for a men's shed nearby, and you were going to get back on your exercise bike. How did you go with all those three?
Well, I've done them. I'm a member of the Centenary Suburbs Men's Shed. I've been active there since earlier this year, and so I find that good. Some enjoyable parts. They make these wooden boxes that people put photographs in, and so my chief job is to sand these boxes before they're finished. So I can tell you, I can sand a box, and no, it's also good social stuff because there's they have a pool table there which we can play at morning tea break. So I've done that, and after hearing your good advice, Alan, I joined the Good Life Health Club at Richlands nearby. I live at Forest Lake, and I took under a 12-week training course with the gym instructor on different exercises and how to lift. That's how to use the body to lift. And so that's been very beneficial. I am currently doing an exercise program called Beat It, which is made available through the National Diabetic Support Organisation, NDSS. And so that goes for 8 weeks and 2 afternoons a week. And so I'm in the middle of that. And so that is good. I could do some more walking and bike riding, I must admit. Just finding the time, I suppose, you know, but an early morning walk will be good, you know. I think that's probably the best time for me. But, you know, I feel well. I tolerate my my treatments very well. I have Alligard every 84 days. And I take two Zytiga tablets when I make up an hour before breakfast. I also take a capsule which is called Duodart, and that's a capsule to prevent or to reduce swelling of the prostate. I take 5 milligrams of prednisolone in the morning. So that is my treatment for prostate cancer. As I said, I tolerate all of those medications quite well. And yeah, the exercise is beneficial to me. I don't feel tired as before. What I was actually in when I spoke, I do remember Alan's comment, beware the slippery slide. And so that jerked me into taking these positive steps. So thank you, Alan. And I can feel tired after I've done, you know, an hour of exercise, like doing some weights, stuff like that. Probably just more that, you know, I am just becoming a bit more aware that my body doesn't give me the same physical strength, capacity, you know. I think I'm still suffering some lingering effects from COVID last Easter, where I puff out a bit more easily if I'm doing some heavier work, and that would be like shoveling soil or something like that. I can mow the lawn okay. I just tend to get a bit breathless if there's exertion going, you know. I have had bone mineral density tests. That's organised through my hematologist, I think it is, who's treating me, who's assisting me with diabetes type 2. And now I have reduced a little bit. I don't remember the exact numbers, but he said you're on the sort of verge of a bit of osteopenia, but it's not osteoarthritis. So we just sort of will monitor you, you know, and I see him once a year. And yeah. And for my breathlessness, I'm going to have a stress echo test with my cardiologist practiced in June, you know. But at this Beat It program, I can walk on a treadmill for 15 minutes at 6.5 kilometres an hour and 2% grade, and my heart rate gets up to about 125, 126. So I think that's okay, you know. I think that's okay. So you know, really, you know, in the scheme of things, and in the theatre of medications that I'm on, I feel really quite well. I feel really quite well, you know. My sleep is sound most of the time. It's just those visits during the night. I wake up at 2 o'clock in the morning or something like that and do a visit, and then getting back to sleep can be a bit of a challenge, you know. Shutting off again. Yeah, but otherwise, you know, like I think I regard myself as being fortunate in the sense of where I'm at with what I'm having. You know, this was all diagnosed in November of 21. So that's about, what, 2.5 years or something, like nearly 3.5 years. And yeah, so I'm continuing on with gratitude, you know. Yeah.
Thank you very much for that, Mark. It seems like you've arrested yourself from the slippery slope you sounded to be on there a few months ago, so which is really, really good. And thanks, Alan, for your help in that. Alan, you'd like to make a comment?
Yeah, it'll have to be a parting comment. I have to go, but as far as the gym's concerned, there is a sort of a habit you need to adapt into. Takes several weeks usually before it becomes a routine and a habit that you hardly have to psych yourself up to do. One of the key vulnerabilities, you're already on top of bone density, which is great. Because that's certainly a vulnerability with the treatment you're on, but so also is loss of muscle mass. So that's why the resistance exercises are important, whether it's weights or whether it's various machines you can get onto in the gym or elastics. Any of those are good. You can do them at home as well if you get hold of some of the elastic devices. But that really is something to become routine as cleaning your teeth. If you can do that, because once your muscle mass starts to go, and it's certainly under pressure, it affects your joints and it affects your general well-being more than you might think. So just a part on exercise really matters. And I
thank you.
have to disappear, so good luck.
Yeah.
You're on the right track on the sound of it.
Thanks for pointing the way. I also would mention I have noticed that I've got some slight swelling, I suppose, or larger looking ankles, particularly more so on the left ankle. And I talked to my oncologist about that. And he said, yes, unfortunately, that's a side effect. I think it's of the Zytiga or the Eligard. I'm not sure which one it was.
I certainly haven't had that side effect, and I'm on a similar regime to you.
Okay.
You may want to have a chat to your GP about the possibility of fluid tablets. Things, there are a couple of those if fluid retention becomes more of an issue. Furosemide is the generic name for them. If it becomes significant, I mean, you don't want to be on any more meds than you have to, but
no, for sure.
Keep that one in the back of your mind if you find your other end starting to blow up as well.
Yeah, I wouldn't call it blown up. Well, it did swell when we went to see a cricket match. We sat in the stadium all day, and that's what really I noticed, is that I had some fluid around the ankles from that, but then it sort of fades after sleeping.
I'm gonna have to duck off now. So
yep.
All right, Alan. Okay.
Thanks, guys.
Yeah, thanks for your support.
Thanks, Alan. All the best.
Yeah. So anyway, that's sort of that's where I'm at. And,
oh well.
Yeah, I'm really I'm surprised in a good way to hear that people have been on treatment regimes for so long. Yeah.
Yep. And I'm pleased you're finding the men's shed helpful too, Mark. That's really good news. Now, Paul, would you like to say a few words? Tell us a little bit about yourself, please?
Yeah, sure.
Thank you.
Yeah, so I turned 60 last year. And I had the PSA checks earlier last year, and it had gone up to, like, from my previous readings, it had gone up to about 2 or 3. So then I went to a specialist, and he did the digital check, and he said, no, you're all good. But then my GP this year said, oh, it's time for another PSA check, which was pretty timely. So it had gone up to about 7 or 8 in March, and then April. Yeah, sorry, 7 in March, 8 in April. So since then I've had the biopsy and the PET scan, and so the PET scan showed that there was aggressive cancer in the prostate, and some had escaped into the lymph nodes. So sort of tracking up the spine, the lymph nodes up. I'm not sure how to describe it, but yeah, tracking up the spine. So the treatment they've recommended is I go to the Icon Centre in Holmes Glen in Victoria. So the treatment they've suggested is, well, I've started 2 Fridays ago. I took the hormone, or had the hormone injection, and then I'll have another one in 3 months. And then on that Sunday following, I started taking the capsules, which I think 4 capsules every day at the same time. Not quite sure of the name of but I think that's to treat to lower the testosterone that's that's generated from the adrenal gland. I'm not sure if that's right, but and I start radiation on Monday, so I've got 20 sessions. Yeah, so it's all, it came as a big shock, obviously. Particularly last year when I got a clean bill of health, but thankful to my GP for being vigilant. Because my urologist said, I don't need to see you for 10 years. So if I'd taken that advice, obviously it wouldn't have, so it was good to be vigilant. So, so that's where and after the first couple of weeks, obviously when you're waiting for diagnosis, it's pretty shocking, for both me and my wife, because you just wake up in a cold sweat. But once you have the diagnosis, I think you just adjust to the new situation, and as you've all said, with the advancement in the treatment and the number of different treatments, and access just to the facilities that we do have, it's pretty, being positive is it's not hard to be positive, I think. So that's my situation. So 20 sessions start on Monday. So 5 weekdays and then the weekend off, and then for the month. And then now the baseline, they did a baseline check of the PSA just when I started the hormone treatment, so it got up to 21. So I imagine that now, that'll come down in 6 weeks, or probably more like 4 weeks now. I'll have another PSA, so I imagine the PSA levels will come down. I'm not sure to what extent, but look, coping with it pretty well. My wife sort of struggles, tries not to be too emotional in front of me, sort of thing. But just from my point of view, work's pretty supportive. So I've just, for the next month, just work from home and get the radiation in the middle of next week it's at 1:30 in the afternoon, so that's pretty manageable. It's only about 10-15 minutes from home. So that's where I'm at.
Thanks very much for that, Paul. Whereabouts are you? Where do you have your
I'm
radiation?
in Blackrock at Holmes Glen, the Icon Cancer Centre at Holmes Glen in Moorabbin in Melbourne.
Yeah.
And I live at Blackrock.
Right.
So
Right.
It's
12
minute. Yeah.
Your PSA certainly shot up, didn't it? So it did.
Yeah.
Yeah.
It certainly did.
Do you know what Gleason score you were?
So
do you know your Gleason score?
Yeah, I think it was. Yeah, I think they said one side of the prostate was 9 and the other was 10, something like that. So I think it was really aggressive.
Yeah, it's 2 numbers that make up the 9. It's not. It wouldn't have been 9 on one side. Yeah, so it would have been 5 and 4, or 4 and 5.
Yeah, maybe it was 5 and 4.
Yeah. But
So,
sorry.
So at that stage, its surgery wasn't not a practical option. I think they said, because it's already escaped sort of the capsule or the
Yeah, no, that's true. That's right.
Mm.
Any comments or questions to Paul?
Jim here, just to say, Paul, that sounds like your doctor is giving you a fairly standard treatment. You're having an ordinary hormone therapy. That's the one you're having every 3 months, and you're having a second level hormone therapy. That's the one that you're taking tablets daily, and you're having radiation, and you're having external beam over 20 weeks. Again, that
20 sessions.
20 sessions, I should
Yeah.
say. I'm a bit slow this morning.
That's
Over 20 sessions. And so long as everybody's watching everything, that's fairly standard. If you're looking towards your next treatments, the fairly standard one would probably be the chemotherapy docetaxel. But this depends on what your doctors might recommend at the time, and hopefully that's a long way in the future. What you have heard mentioned earlier today is you want a big thick file of all your results and your scans and so on, so you can read them off for your doctor's visits, and perhaps if you want to talk here as well. The other thing is if your wife's program allows it, if she can accompany you to visits or someone else, that's a good idea. If she's not, I've never heard of a doctor turning down a request to record the session so your wife can hear it. And if they do, then the next time you turn on your recorder before you put it in your pocket and go inside, because you're entitled to, in Australia, record, well, I think in all states, to record stuff which affects you and which you're a part of. You're just not allowed to publish it, but they'd be flat out finding you published it to your wife. Thanks, Paul. Thanks, Nick.
Yeah.
Thanks, Jim. Any other
Thanks, Jim.
questions or comments to Paul? Yes, Yanni?
By the sounds of it, Paul, you're on, as Jim says, first generation hormone treatment injection that lasts for 3 months, and then the 4 pills that you take. That's possibly enzalutamide, or otherwise known as Xtandi, which is one of the second generation treatments that is particularly effective. I'm on it. I've been on it for 5 years, and for the period of time that I've been on it, my PSA has been 0.010. So it can work very, very effectively. I think you can look forward to a massive reduction in your PSA over the coming periods. The other suggestion I might make, particularly if you've got a friendly GP, as I do, is to go see him and ask him for a bunch of Melbourne pathology blood test forms, and go every month or 2 months or whatever you're comfortable with, and get your PSA tested, and then monitor it yourself so that you can get some sort of heads up as to even minor changes in your PSA, whether it's dropping or whether it's rising or whatever, so that then you can be on the front foot rather than wait to go see a specialist every 3, 4, 6 months or whatever. And the pathology forms that you get from your GP, if they don't put your name on the bottom of the list of recipients, you just write it in there, and then they will send you a copy of the blood test results. just put your normal street address or PO box or something like that, and then you know, you're sort of ahead of the game.
Yep. Okay, then that's a really good idea. I've got another one in 4 weeks, I think, with my medical oncologist. So, but yeah, it's a good tip, and I'll keep those regular PSA checks.
Thanks,
Jim
Tony.
here.
Thanks, Paul. Any other questions to Paul or comments?
Jim here. Oh, sorry, am I muted? No, I'm here. Can you hear me?
Good. Yep.
Right, you can hear me. Sorry. The PSA tests, both of the drugs that you're taking should see a fairly rapid decline. However, radiation decline can take a long time to start and go over a long period. So typically, you don't see any results from the radiation for at least 6 weeks. Most people with radiation do see their movement within 18 months, but some people don't see it for years. So just bear that in mind.
Yeah. It's interesting that it takes that long to kick in.
Well, what happens is the radiation will damage the end of the DNA in all your fast-growing cells, and that one of those is cancer. So the cancer doesn't die immediately. It does in the spot radiation people we've been talking about, where they hit it with a very focused high dose. But ordinary radiation just damages the the DNA in that little string at the end. And the reason for that string at the end is to repair damage in your DNA. You're having damage to your DNA like everybody else in the world, or every hour of the day. And your cells are actually repairing that every time the cells go to reproduce themselves. So when the prostate cancer cells decide to reproduce themselves, then they find they can't. So that's the reason that it takes so long. And that's the reason that other quickly replicating cells in your body, like your bowel, well, your whole tract from your mouth. Oh, I didn't want to show a mouth, did I? From your mouth down to your rear end, because that tract can have all sorts of alkalis and acids and noxious rubbish. Those cells get changed every 2 to 3 days. So there's sometimes an effect on them. But sorry, that's a long story. But
No, interesting.
Yeah.
Thanks, Jim. Tony Sheehan, do you want to say something?
Well, it's working opposite to the way it should. But just as a follow-up to what Yanni said about blood tests, I would suggest, Paul, that you also get your testosterone measured as well, because that's a good way of determining whether the hormone therapy that you're on is effective. That's basically all I've got to say.
Yeah, thanks, Tony.
Thank you. And is that with the blood test?
Yeah.
Just a general observation. Since I've been on this fun trip for a while, I've subscribed to quite a large number of medical journals and general stuff relating to prostate cancer treatments. And one of the things that my objective is, and I guess everybody's objective is to die with prostate cancer rather than from it. Now, as Jim mentioned a while ago, there's been an amazing level of discovery and revelations in new prostate treatments over the last decade whilst I've been affected. And through these journals and what have you, there are regular posts on new medications that are showing promise and that are either in various trial stages, stage 1, stage 2, or stage 3. Stage 1 is where efficacy is assessed. Stage 2 is where dosage limits and side effects are assessed, and then stage 3 is where the optimum dosages are assessed. And for anybody who's concerned about where your future may go and what the future may hold, I'd urge you to try and discover sites in each of your states that list where trials are available and what sort of trials you may qualify for. For example, there are quite a large number of third-generation androgen receptor inhibitors that are in assessment, and they go under these these cryptic names until they get a commercial name, like ODM 208, ARV 110, which is called bavdegalutamide, or Epi 7386 masofaniten, or TAS 3681, or Certuvivint, or ONCT 534, and the list goes on and on and on. So there's a lot of potential opportunities, maybe not today, but down the track, even as in the short-term future, as soon as 6 months, a year, 2 years, whatever, to participate in some sort of testing or assessment of all of those medications. So if you're interested, do maintain a regular sort of watching brief on what's going on in the prostate cancer development space, because when time comes and I'm found to no longer be reacting successfully to my enzalutamide Xtandi, then my theory is that I'm going to, with a fine tooth comb, go through all this alphanumeric soup and try and work out what stage each of these new medications is at, so that I can put the hard word on my medical oncologist and say, what about this one? What about this one? What about this one? Just a thought.
Thanks, Shani. I appreciate that. Thanks. You got anything? Any other comments, Paul, or you right now? Or?
No. Look, that's been really good. And just those comments in the chat, they're first generation, did you say? Hormone treatments?
The injection that you're having is a first generation treatment. It's likely Zoladex or Lupron, or Diferoline or something. And the 4 tablets you're taking are likely enzalutamide / Xtandi. That's a second generation treatment.
Yep.
Thanks, Shani. Thanks, Paul. Bob, down at Grafton, are you
Thank you.
like to give us an update?
Oh, yes, here I am. Last month I mentioned that I went for another PSMA test and CT scan that metastases had disappeared. And because they had disappeared, that made me then eligible for radiation, or more than 5 at the beginning. That's 2 years ago. Now they have dramatically shrunk, well, that's my word, they've shrunk or disappeared. And last Wednesday, this week, 2 days ago, I went across and had those judicial seeds inserted, and the barrier that goes under the prostate between that and the rectum. And I'm waiting for a phone call either today or Monday as to when I go for the initial, I think they call it a sim or a simulation setup, where they work out exactly where they're going to put the radiation, so they get the measurements and the location exact and precise. I think that will probably be next week, and then shortly after that, they will start the radiation. But unlike Paul, I'm only going to have, this is when I was talking to the radiation oncologist, 1 session per week for 6 weeks. Now, I assume, I don't know, I haven't had a chance to ask you yet, but that's going to be a higher dose, which is why it's not going to be every day of the week. So at the moment, I'm just in this waiting stage to start the radiation session. In the meantime, and all this came about, this PSMA test about a month ago came about because the PSA was gradually increasing, went from the base of 0.25 up to 1.1 in about eight or 9 months. That's why I went for the next PSMA test, and it showed that the metastases, as I mentioned, had gone, or appeared to have gone. And why it went up, I'm not sure. Why the PSA went up, I don't know. But now, as I say, they're putting on this radiation once a week for 6 weeks. And that's where I am up to now.
The name of the thing you were looking for before, Bob, was space ore, that between your prostate and your bowel. But anyway, that's besides the point. Jim.
Space ore is one of 2.
Sorry?
Space ore, I'm telling Nev, is one of 2 brands that are available. They're slightly different in their actions. But on questions, first of all, of the simulation, the idea of that is that your radiation oncologist and your physicist will try a whole lot of different plans of directing the radiation, you know, this way or that, and this strong or that strong, or so on. Or actually, they'll probably have a computer generate a whole lot of different scenarios, and then the radiation oncologist will look at the pattern of radiation that will be delivered into your prostate and around your prostate, and check that that's what he thinks will do best. So then that simulation will be cemented in place, and that'll be what your radiation machine follows for the next 6 treatments, which brings me to the number of treatments. We know, because we've got data for about 30 years, that the 20 treatments will work. However, throughout the world, when COVID came in, first thing that was well, the first thing that was actually turned off was all the trials that were going on, that they had to be stopped and nobody new put into trials. And the second thing was they weren't allowed to have these long sessions of radiation, 20 over 5 weeks, or another one is over 7 weeks, 35. They stopped all those. So what they did is then they were forced to find some alternative, and the alternative they found was some new patterns of treatment that were being tested, and for which we only have 7 years of data, 7 years of results, and that wouldn't normally be enough to say go. You'd be wanting to wait for at least about 12 years usually before they make a treatment standard. But there was no choice, so they went to shorter treatments with as you say, a higher dose, and it turned out to be quite good. And now they're trying lots of different patterns. They start at 5 treatments in 5 days, or 5 treatments in 7 days, or 5 treatments in 10 days, and go to all sorts of other patterns. And the one that you're being offered is 6 in 6 weeks. So that's to be expected at the moment. The doctors who were worried, some of them, perhaps all of them, everybody's worried that there might be some kind of recurrence of some kind of virus, or a new variation of the old viruses that forces lockdowns again. And so that's why you're getting from the 7 years of data, it was equivalent. The only difference in the 7 years to the longer doses was in side effects. The higher doses, as expected, have slightly more side effects. But from the 7 years, the results as far as quality of life and length of life were equivalent. So I hope I haven't confused the issue there. But it'll be fairly standard offered. That sort of treatment would be fairly standard offered around Australia. I hear it a lot, that people are having these reduced but stronger treatments, mostly. As a matter of fact, the 20 we heard about today, I've only heard one other in the sort of the 2 months that I've been out of hospital, and been taking calls from directly from PCFA. Any questions on that, Robert? Bob?
No, I'll have a clearer picture, I imagine, on next week. Yes. It's a lady, radiation oncologist. I'll ask her and try and get a clearer picture for myself as to what the plan is.
Yep.
Right, yeah. Someone wanted to say something?
My advice is so don't panic if that's what you're being offered. That's fairly standard at the moment, and perhaps forever. Could be.
We wish you well with that, Bob. So we do, and we look forward to an outcome.
I'll let you know next month.
Yeah, good man. Ian, up in Charters Towers.
There we go. Right.
You put yourself back on mute. You took it off and then you put it back on mute.
Okay, so we're right?
Yeah, you're right.
Okay, so I saw my oncology specialist end of last week. And the last 2 PSA readings have stabilised at 7.1. So they're just going to continue with the Xtandi and with the treatment as it has been. No new sign of, although he has talked about doing more rounds of doxytaxel, but on a fortnightly basis. He's quite happy just to leave it with the PSA stabilised at 7.1. He's quite happy apparently just to leave and just watch and see whether it's because it went down, and when I started Xtandi was November last year, and it was 60, gotten back up to 16.8. After I did start Xtandi, went down to 11, then down to 6.8 to 7.1, 7.1. So we're continuing with the Lucrin injection every 3 months, and the Nosomorb every 3 months. And that's at this stage. It did in the latest PSMA. There are lymph nodes in the lymph nodes. It's moved to lymph nodes as well as the bone, the spine, the pelvis, shoulders. Yeah, it's pretty aggressive apparently. So yeah.
Do you have to go to Townsville to see a oncologist, or?
Yes.
Yeah.
It's only it's an hour and a half drive.
Yeah.
Have the first, we actually go down the day before and have the first. I have the 8 a.m. Appointment.
Oh, right. Yeah. Any questions or comments to Ian? Well, we wish you all the best, Ian. It's been ongoing for a fair while now, hasn't it?
We're 8 years in, and considering when I had the fall, they only found it. They did CT scans for broken bones, and there's a workplace incident, and no broken bones, but a body full of metastasized cancer. PSA recorded on the day was 400, so that, forget about workplace cover or anything like that. And that was done at a regional hospital, those tests. So then did urgent transfer to St. John of God Subiaco at the Bendat Cancer Centre. So I spent 3 months in hospital there while the lowest it's been since then is 0.04. As I said, it's sitting at 7.1, and because of the fact that back in 2018 it was 400, then they're not. When you take that into consideration, you've got to have purpose. You've got to have a good mindset. If you don't have either of those, they can give you all the medication in the world. If you give up, the medication won't save you.
Being positive certainly helps. I couldn't agree more with you on that one, Ian. Yeah. Do you know what year it was you were diagnosed?
Sorry?
Do you know what year it was you were diagnosed?
March 21st, 2018. I was
2018. 57. Yeah. All good. Yanni.
Ian, is there any possibility for you to get a lutetium treatment?
The only possible that he's talking about is doing the doxytaxel again. Like back in 2018, in hospital in the cancer ward, I had 7 rounds of doxytaxel and 5 rounds of radiation treatment. I've had since then to date, I've had 50 rounds of radiation therapy targeted, and still only 7 rounds of docetaxel. He is talking about doing docetaxel again, but he wants to see what the Xtandi will do. He's still saying it's early days with the Xtandi. So I'm still pretty active, but it did take, gentleman commented on loss of muscle mass, and yeah, that's a real factor. My occupation after then, I was carrying ammonium nitrate to the mine. So over 30 years as a long distance truck driver, I was pretty, I had good upper core strength, and that's all gone. They classed me unfit to go back to that sort of work. And look, my concentration in driving, I can't even drive to Charters House without losing concentration. My wife does. I'll do some drive, but my wife does a fair bit of driving these days. And I just play with, my hobbies are, I've got a 69 Mach 1 Mustang, which at the moment I'm putting a brand new wiring harness in. And that sort of thing. I'm not working. I did have a job up until we moved from Kalgoorlie to Charters Towers, and I haven't been able to get a job, but I've decided not to go back, not to rejoin the workforce, and just going to concentrate on my cars. And I try and keep on top of where I'm with this, and I'm like, I have some down days, there's no doubt about that, but most of the time I feel pretty good. My wife, she can tell, she'll look at me and she'll just say, how's the pain reading today? Or, because I try not to worry too much, but she can read me like a book now.
Jim here. Jim here, Nev, please. I'll comment on Ian's case in a minute, but before people maybe start to go, if you go to jimjim.com, that's just 4 gyms in a row, .com, nothing after the .com, you will find a contact button. And when you click on that contact button, that'll enable you to contact Nev or I by email, or Nev by SMS. Sorry, never had to pop that in because sometimes people head out at 11 o'clock. Ian, docetaxel is a cut and come again drug. That is, if it works the first time, there's quite a high likelihood it will work the second time.
Yep.
Sometimes people have been reluctant to go on a second course because the first course didn't bring their PSA down. But when you go into it, it actually kept the PSA level. And as you've been hearing from your doctors, they're happy if your PSA remains level and it isn't going up, especially when you get into these advanced treatments. We've had a member who was for some years hovering around a PSA of 170, 170 or 270, never, I've forgotten. Whatever, it might have been 270. But because it was hovering around there, his doctor was happy, and he also was giving enormous amounts of treatments. He had 20 docetaxel and 61 cabazitaxel, the next one. So thanks. And first question from Ian, and thanks, Nev, for letting me butt in.
Thanks, Ian. We wish you all the best. Yeah, you're a fighter. We know that for sure.
Yep. Can I just make one other point on the docetaxel?
Yeah, go on.
I went to the lowest of lows with that stuff. It's not a nice. Wasn't nice at the time. That's why I was in hospital for so long. They did most of the docetaxel in hospital, but it brought it from 400 back down to that 0.04. So you just gotta.
So that's common. Nobody says they love it. Some people say they tolerate it. There's Ian that I was talking about a second ago over in Western Australia. He seemed to take it like cleaning his teeth. But most people do find it bothersome. However, after the treatments, there's almost universally a recording of a higher quality of life.
Yep.
So your experience is a fairly common thing.
Yep.
Thanks, Ian, and all the best. Yanni?
Jim mentioned cabazitaxel. That's another version of chemo, and from what I know, it's generally reserved for use after docetaxel, but it doesn't have as many side effects as docetaxel, from what I understand.
Jim here. You're right that it has fewer side effects. The reason it goes after docetaxel is purely economic. The government has to be very careful with the money we spend, or our money that they spend, and cabazitaxel is much more expensive. So they always say you can't have it unless you've had docetaxel first, because docetaxel costs not much at all to buy. And so that's enough on that. Thanks, Nev.
Jim, sorry, Tony.
I'm sorry, everybody. I've got to leave at the moment. I've got something else I've just got to do.
Yep, that's fine.
I'll be in contact with Jim and Nev about next month's meeting, but I'll get back to you on that. So, good luck, everybody.
Yep.
See you later.
Thanks, Tony. I'll just go quickly to George, and then we'll close it up. But I should say at this stage, Katie Owens, the researcher at Peter Mac, was going to be with us today, but she had student commitments that come up, so she had to apologise. So there you go. That happens. George, have you got a quick update for us in Dubbo?
Yeah, not much happening. I've got blood tests in early August, and I assume it'll just be a low PSA number, if any at all, and I'll have another Zoladex implant and continue on.
How many years?
Probably about 14.
Yep, all good. Thanks for that, George.
Okay.
I'd just like to say thank you to everyone who come along today, and a special thanks to Paul and Nick for their attendance. I hope they got something out of the day, and we look forward to seeing you again in the future. Yeah, rightio. All the best, everyone. Goodbye.
Thank you.